Hello to everyone out there. Welcome to UF Health Wellness University webinar. I'm Marcia Mott, the coordinator for the UF Health Wellness University program. Thank you for joining us today as we discuss the very important topic of maintaining good vision. I'd like to introduce to you our speaker, Dr. Jessica Cameron. Dr. Cameron is an optometrist at the UF Health location in Gainesville, Florida. This is the newest UF Health practice and is located inside the Oaks Mall in the former Sears store. We relocated ophthalmology, ENT, audiology, as well as related outpatient surgeries to this building in 2020. Dr. Cameron joined UF Health in 2014, and since then she's been active in her teaching roles at the University of Florida, as well as the North Central Florida Optometric Society. She enjoys caring for her patients at the new UF Health location and strives to treat every patient as if they were family. If you have questions for Dr. Cameron, you can submit written questions at any time using the Q&A button at the bottom of the screen. At the end of the presentation, I will read your question anonymously. We will not be using the raise your hand feature that you may see at the bottom of the screen. All questions will be submitted in writing. I will try to get through as many questions as possible before we end our talk today. Dr. Cameron, I'm going to turn it over to you now. Thank you.
Thank you, Marcia, and good morning. Let me get my PowerPoint up here. All right, so it's my privilege to speak to you today about don't take good vision for granted, specifically focusing on living with visual impairment, details of a low vision exam. So a little bit about myself. Yes, I'm originally from Florida, and I completed my residency at the Malcolm Randall VA here in Gainesville, and that's what got me here. And now I'm a proud Gator. I have been with the University of Florida Department of Ophthalmology for about 6 years now. I primarily treat patients with ocular disease. However, my specialty here is specifically working with individuals that suffer from visual impairment, or what I would call low vision. I will be talking about many topics as well as visual aids, as well as companies. So I want you to know I do not have any financial disclosures. So some objectives. I know this slide might be a little daunting. It's a lot of information, but we are going to cover a lot of information today. Specifically, we should walk away with the understanding of what the definition of visual impairment is. Some normal aging changes to vision that can, well, I should say to the eye, that can impair vision. Knowing when to identify visually impaired individuals and how to help them, whether they're family or friends or even a stranger. We are going to walk away understanding really what I do in clinic as a low vision specialist, because a lot of times when patients get to me, they don't really understand why they're even there. And so we want you understanding why, when you come in for a low vision exam, what your expectations should be. Having a better understanding of visual aids as well, I will touch on that. And then understanding additional low vision services outside of the exam room that might be available to our community. So really, what is visual impairment? It's by definition by the American Foundation for the Blind, it is vision loss that may be severe enough to hinder an individual's activities of daily living. You're going to hear me say activities of daily living quite frequently, and sometimes I do refer to it as ADLs. These are activities that we take for granted, that we do every day, might be very simple, such as walking to the mailbox, reading the mail, preparing meals, readings, normal size fonts, things like that. And these are going to be activities that individuals with some visual impairment will struggle with on a day-to-day basis. Now, sometimes patients, it depends on the disease process, they will retain some usable vision, whether it's for mobility or for light perception, for walking, for understanding their home layout, things like that. Now, when I talk about visual impairment, usually by the time patients get to my office, Everything has been exhausted as far as therapy, or they are currently undergoing therapy. There is no more surgical options for them, as well as we do try or attempt to improve vision with glasses, and sometimes this is not something, a goal that we can attain. So we don't know until we really assess the patient, but usually when you get to a certain visual impairment, all of your resources have been exhausted. Individuals that have visual impairment do struggle with contrast sensitivity, which really simply means that it's trouble seeing an object, or whether it's letters on a page or a cup on a table. They have trouble discerning the edges of certain objects. They may have light sensitivity, glare sensitivity, and trouble with light and dark adaptation, walking from one room to another or from indoors to outdoors. So I want you to understand that this is a worldwide problem. You know, of course, I'm going to focus mainly on the United States and the demographics of the United States, but this is a worldwide problem. 285 million people are visually impaired, 39 million are completely blind, and 94 million older individuals in developing countries do suffer from moderate to severe visual impairment, and this is twice as many who suffer from significant hearing impairment. As you can imagine, visual impairment can impair many roles in someone's life, as well as severe personal, social, and economical consequences. I did throw in this table to show you an understanding that, you know, our population is aging gracefully, and those baby boomers are moving on up, and that means more patients to manage. So that's why visual impairment really is something everyone should know about. So what does this mean to you? So I have a few of these slides kind of thrown in to help you kind of maybe reflect on your own life, maybe even family members or a loved one, a friend, you know, visual impaired. You might have to help someone or give care to someone that has visual impairment. But really, we want to help you better understand what it really means to have low vision or be visually impaired, and to be aware of how to help those individuals and care for them. Something as simple as a visual aid, such as a handheld magnifier, is classically one of the most common visual aids known to just the layperson. And yes, it is commonly used. It can commonly be picked up and purchased at any store. And sometimes even individuals at 40 years old feel like they need that handheld magnifier for some of the small print. But sometimes just glasses can help with that. But yes, a handheld magnifier is one type of visual aid. Visual impairment might mean also other health concerns. Usually these individuals do have, you know, high blood pressure, diabetes, many other diseases that can affect their daily activities that are not related to vision. I did throw in the topic of geriatric. That's not true. I actually have quite a few patients that are younger and middle-aged that have congenital diseases that affect their vision, and I work with them and I try to keep up. We'll just keep it that simple. Younger individuals do very well with digital devices, and they run circles sometimes around me. So not all this specialty is not just for elderly. Another thing is driving privileges. That is the burden of one of the things I have to discuss with every single patient. And so I will kind of go into a little more detail farther along in the lecture. And then of course, fear for the future for yourself or your loved one. Maybe one of the diseases I do discuss today is something that runs in your family or that you might already be diagnosed with. So hopefully I'll be able to talk a little bit more about that specifically. A few statistics. I know I'm trying, some of this is maybe a little bit boring, but we got to throw in some statistics here. But the major causes of visual impairment is age-related macular degeneration, glaucoma, diabetic retinopathy, and cataracts. But the leading cause is age-related macular degeneration that causes legal blindness in the elderly individuals, specifically Western societies. And it affects many people worldwide. It's estimated that age-related macular degeneration affects as many people as Alzheimer's disease or related dementias. And this is now very, very common. There's a lot of information on age-related macular degeneration, a lot of awareness. And so that's going to be kind of my main topic I'm going to discuss. But a few others. So I kind of broke them into small categories. Degenerative or age-related, of course, the number one affecting vision is cataracts, but this is completely preventable and treatable. Usually a one-time surgery and done for most people. So completely preventable, but yes, cataracts can affect your vision. Secondly is age-related macular degeneration. Thirdly, Fuchs endothelial corneal dystrophy. Acquired, there can be many things, trauma, stroke, amblyopia, which is something we call a lazy eye, where an eye will just not function well to see perfect 20/20, whether it's turned or not turned. Glaucoma, as well as retinopathy, whether it's related to hypertension, diabetes, or cancer. Congenital or inherited. I'm simply going to keep this a very small category because it is quite large, but the most common is retinitis pigmentosa, albinism, and optic nerve drusen. Now, I mention all of these. I see all manner of patients with all of these diseases in my low vision clinic. It is definitely one of the privileges that I get to see sometimes very rare diseases that affect individuals' vision in my low vision clinic. But this, again, is a very, very small grouping of those diseases, okay? The disease description for causing low vision is very vast. So just a quick overview of the eye. This is just a quick schematic. Anteriorly, you have the cornea, and then light flows through the pupil in through the lens of the eye. The lens is where you'd typically have a cataract, age-related cataract, and that would be removed if you had a cataract in that case. But then light travels through the gel of the eye and back to the fovea, and then light is transmitted through neurons that go through the optic nerve. Now, this is a normal color fundus photo of the retina. You can see here, just a quick description here. I always like to call the optic nerve, it looks like a golden, kind of orangey golden disc. Centrally, you have the optic nerve cup. This is very important if you're trying to figure out if someone has glaucoma, judging the cup to disc ratio. Emerging from the optic nerve is arteries and veins, okay? So that's why all these blood vessels kind of come out and flow out from the optic nerve onto the retina. You'll see there's an avascular zone, which is your macula and specifically your fovea, and that is where you would see 20/20, okay, or the best vision possible. Now, these are pictures of a few diseases. Some of them I have already touched on. And you can see that the retina does not look like the previous slide, right? It's not evenly toned orange. There's multiple coloration differences to the optic nerve and to the retina. The top left corner, that is a disease called retinitis pigmentosa, where the retina atrophies in the periphery, leaving the central looking more normal. But as the retina atrophies, it deposits these dark kind of bone spicule deposits. The bottom left is called Caroteremia. This is it's a rare condition. I have seen it quite a few times in my low vision clinic, but it is where the retina actually atrophies and you can see the underlying vascular layer. A lot of these diseases are quite beautiful, but sadly, very, very bad visual outcome. Centrally, you have optic neuropathy. That's where the optic nerve is no longer that kind of golden disc or orange disc. It becomes very pale, and that tells us that the cells have atrophied or are no longer there and functioning. Now on the top right, that picture looks very similar to optic neuropathy, but this is actually a congenital condition called optic nerve head drusen, which are calcium deposits of the optic nerve. Again, they can disrupt vision, but this is a little bit more benign, okay? And then on the bottom right is Fuchs corneal dystrophy. As we know, the cornea is the front surface of the eye and it should be very clear. In Fuchs corneal dystrophy, the cornea does start to wrinkle and opacify, which means that it becomes edematous and it does not let light as clearly through it. So definitely can affect vision. I'm going to specifically talk about two diseases that I see very commonly in my clinic, probably my most common patients. Age-related macular degeneration is one of them, and it causes significant central vision loss. It is the most common cause of irreversible central loss. It affects individuals 50 years or older, and it's estimated that 15% of the Western population has signs, but only 1 to 2% progress to vision loss. The underlying etiology of this disease is, and it might be a little difficult because I don't have a pointer here. I love having a little laser pointer. But in this schematic picture down on the bottom, you can specifically see that there is an icon that's drawn to like a little yellow space that's called a drusen. So the cells of the retina are very metabolically active. So they're active, active, active. They can deposit small little wastes. Usually those wastes are taken away and away from the cells and do not deposit underneath the cells. But in age-related macular degeneration, there's a genetic component that does not allow the waste products to be removed from this cell layer. So the deposits continue to grow in size and more numerous until essentially they're quite large. These drusen deposits then essentially keep the retina cells from receiving nutrients, and then the cells do atrophy or die. Very, very sad. You can really see the yellow deposits in the top right picture. That is a dry age-related macular degeneration because there's two types, okay? So the dry is definitely the most common. It can lead to significant vision loss from something called geographic atrophy, which is where the cells slowly die. And if the cells are no longer present, you have central blind spots that affect the central vision. There are minimal treatments for this stage, right? So dry age-related macular degeneration, the main things you can do is 1, if you're a smoker, stop smoking. 2, nutraceuticals, which is a fancy word for multivitamins, specifically lutein, zeaxanthin, are over-the-counter supplements that you can take. But really, if you just have a good diet, rich in leafy greens, high in antioxidants, rich, colorful fruits and vegetables, this can overall help you get the lutein and zeaxanthin you need to keep the retinal pigment as numerous and dense as possible. The other thing you can also do is, of course, protect your eyes from the sun, hats and sunglasses, okay? But at any point in time, dry age-related macular degeneration can turn to wet. The wet kind, is very serious. You have very acute, quick vision loss and is usually central. There is a therapy, though, that works quite well. I know because I actually personally have 2 grandparents with age-related macular degeneration, and both of them are getting treated with eye injections with anti-VEGF therapy. I know, very scary, but this therapy by far is just wonderful. Both my grandparents have gained back their vision to a point that has had some atrophy to the certain areas that were affected by the leaking. But this treatment works miraculously and it stabilizes the disease process. But it can be quite daunting to imagine getting a shot in your eye. But I promise you, it actually does not hurt. You will not feel a thing because we numb the eye quite well. So, okay, moving on from that, because most people freak out about the eye shots and then they defer therapy. Please don't stop therapy and don't defer therapy just because of a little shot, okay? Because it works very well. Like I said before, kind of moving on, complaints that I do notice with my patients with age-related macular degeneration that they complain about in the room is that something we call metamorphosia, which is where straight lines will appear bent or curved. They will also complain about missing letters because of the small blind spots. Some letters in words will be missing, as well as they struggle recognizing details, small details, recognizing faces. things like that, seeing the phone, seeing pictures. It's quite sad. The second disease I'm going to talk about, because it's very common, again, another patient role that takes probably about 50% of 50% of my patients that I see in low vision is glaucoma. Glaucoma is damage of the optic nerve that causes irreversible peripheral vision loss, and it can affect any age group. Most at risk is greater than 50 years old. 3 million Americans are affected, but sadly only half know or are aware that they have the disease process. If you want to look in the top right corner, you'll see that a normal optic nerve has kind of a small cup, which is that really white circle area in the middle, whereas a glaucoma or glaucomatous optic nerve that is sick and damaged kind of has an elongation vertically of that cup, and the nerve essentially is losing cells superior and inferiorly on that disc. The most common thing that we can treat with glaucoma, or really the only thing we can treat with glaucoma, is managing the pressure. And we do this by either using, we have many drops to use, but lowering the intraocular pressure via drops. Secondly, we can use laser to lower the pressure of the eye, which helps the drainage system of the eye to lower that pressure. And thirdly, in advanced cases, if those two therapies do not work or fail, we do have surgery, okay, to shunt or move fluid out of the eye, okay? The most common complaints from my glaucoma patients always have to do with mobility. So if you're losing peripheral vision, you're gonna have trouble running into things, tripping over things. In your own home, this will not be an issue. It's unfamiliar environments. In advanced glaucoma, yes, central vision can be affected and you can have complete lights out of vision. So that would be very, very concerning. Moving on, I am going to touch on just two more things here because I do see quite a lot of traumatic brain injury. This is a college town. We have lots of athletes, as well as there's lots of fender benders, okay? So traumatic brain injury can kind of vary from very mild, moderate to severe. It depends on a lot of other factors such as age, the health of the patient, the injury itself, location of the injury. And really with data, it definitely shows that there's varied kind of visual disturbances related to the trauma. This is a large range, 30% to 85% can have visual disturbances. How would you know? Well, if you're an individual that has suffered trauma and you're having trouble reading, focusing, concentrating, seeing double vision, these are all side effects of a traumatic brain injury as well as a concussion. Sometimes we can help these patients, and sometimes it's that we have to kind of wait for this interim period of 6 months, sometimes to a year, for the patient's own system to kind of recover. There is occupational therapy that can be used. There's vision therapy. Sometimes we can prescribe glasses to help at near and prism. And then miraculously, the patient does recover. In most cases, as long as the traumatic brain injury is not severe. But these patients do have very odd complaints. They skip lines when reading. They have trouble focusing. The comprehension is an issue. They could read a line over and over and they just say, I don't know what it says. So imagine a student or an athlete having to complete their schooling, and now they really are suffering to where they can't focus. So very, very difficult. I do want to touch on stroke as well, quite common, okay? And this does lead to vision loss secondary to blood flow changes or loss to the brain. If a part of the brain that's affected has visual radiations going through it or the visual pathway, then the vision will be affected as well. But normally most individuals will have sudden speech, weakness or paralysis on one side of the body, and then sometimes unluckily, they will have vision loss. That vision loss, I do say about 6 months. It's going to recover roughly in 3 to 6 months. It will recover. What's left after 6 months, usually we see is very stable. This is concerning because usually it's both eyes affected, and the most concerning defects I've circled here. do limit your ability to drive in the state of Florida. But it also can have mobility concerns. You could trip or fall, trouble reading, and a few other things that really take some lifestyle changes to adapt to. In general, this is kind of a general slide encompassing everything. When someone comes into a low vision exam, they could say they struggle with all of these things. So I kind of wanted to touch on everything. We know that age-related macular degeneration affects more of near tasks. You know, I can see your face, but I can't see, you know, you coming towards me, or identifying your facial features. I recognize your voice. They may suffer from not being able to read normal size fonts. Again, activities of daily living. For distance, trouble seeing road signs, seeing the TV. Computer usage, I did describe here as a mixed response, because I do have patients. We are a digital society. More and more people are using phones, tablets, computers to be able to continue to function. And I'm very glad. It makes my job really easy to help them with that, because there's lots of apps out there now. But again, there's still about maybe half of my patients that are not really keen on using digital devices yet. So we kind of have to think outside the box. Light sensitivity is always an issue. Make sure you always wear even tinted lenses indoors. Yellow tint, I do like yellow tint tremendously. It cuts down on a lot of glare indoors, especially with fluorescent lights. And rose tinted glasses, I do suggest those for indoors. Sadly, a lot of people with visual impairment don't really realize they have glare issues until we show them these tints in the office. And sometimes that's the one thing that they walk away from my exam learning, is that they go out and they buy themselves a yellow tinted solar shield, which is a cover over their current glasses, and they're very happy with that. But of course, when you go outside, we want you using a darker lens, such as a copper or amber, or even a gray. Mobility issues is always a concern. We don't want you hurting yourself or others. Tripping in unfamiliar environments, that's always concerning, and family members are always concerned usually for the patient for this. Again, I mentioned activities of daily living. I mean, things we just take for granted. Eating off a plate, cooking for ourselves, starting a load of laundry, being able to fold that laundry, as well as still attending social affairs. What we don't want is individuals just staying home and isolating themselves. That's unhealthy behavior. So moving on, we're gonna now kind of jump into what I technically do as a low vision specialist, what we do in the office, and what our goals are. So a quick rundown, we are doing a detailed case history, just like any other health exam. When you come into the physician, we're gonna ask you a lot of questions, maybe what brings you in, what's your living situation like, and we do an in-depth refraction. So we do try to refract, and usually a phoropter-free environment. So that picture there with the big machine on there, we try not to use that, okay? We use special charts that you do not see on an average exam, as well as we use visual aids towards the end of the exam, which are all hands-on. I will not say that I have or own all the visual aids on the market. That would be immense amount of storage. So I don't have that kind of space. But in general, I have about everything that is needed. And if you want more information, I can get you more information. As well as supportive services such as elder care, division of blind services, Independence with Low Vision, Center for the Blind. I work with all of those entities. So again, we're going to kind of piece through and go through each one of those individually. A good case history is very important. We're going to ask you lots of questions. We're going to ask you what the underlying condition is that's affecting your vision. Have you had a previous low vision exam? Do you currently have visual aids at home? This kind of lets us know kind of how prepared you are in accepting digital devices, handheld devices. If you like to hold things close versus far away, that tells us whether you're going to like magnification that's higher or not. As you can see from this picture, children do not mind getting very close to their work. when they're writing, whereas adults prefer to stay away. They want space and to feel comfortable when they're reading. So that's kind of a big difference between adults and children. And usually we ask about 3 goals that an individual, maybe activities they used to perform that they can no longer perform. One of the most common goals is reading or improved reading, improved watching TV or clarity with the TV, as well as driving. So a little bit about the charts we use. So you're not going to see us use what we would commonly call the chart that you see in every exam that you've ever had. That is the standard of care is Snellen Acuity, okay? We use something called an ETDRS chart, which is a movable, very fair chart that's backlit with letters that cannot really be confused for each other. And it gives a more fair response to individuals than a Snellen Acuity chart. But we also, in severe cases, can walk up a chart that is handheld called Feinbloom. But I find that most of my patients, we kind of wheel around our vision chart, and that's the preferred chart of use. It's very easy and easy to understand and interpret the patient's visual acuity as well as the patient, let's say they were 2400, which is the large E on the Snellen chart. They can actually read letters off of an ETDRS chart. So that's why we like to use it. We want positive feedback. Now, I added this slide in yesterday because I realized that very few people understand really what visual acuity is. What does 20/20 mean? What does 20/40 mean? What does this 20s, what does this mean? And why is that important? So for us as a physician, this is a universal standard for recording vision in a clinical setting, okay? It's numbers that we understand to understand your diagnosis and to understand and track your therapy. This fraction of 20/20 is called a Snellen fraction, and it's simply interpreted as the top number, as we know, never changes. It's always 20 because our testing distance is always 20 feet away, or the data is interpreted in 20 feet away. The bottom number changes based on what letter size and how well you can see it, of course, and this corresponds to the distance at which the letter is designed to be read. My best description of this is not here in the details, is that someone who's 20/20 can see perfectly, okay? Let's say when I take my glasses off, I am seeing 2400, okay? I can barely see the E on the top chart. Someone who's 20/20 would have to stand 400 feet away to see what I perceive at 20 feet away as 2400. So that bottom number has to do with how well that perfect person can see and how far away they're standing. If you wanted to interpret the data a different way, it has to do with the letter size changing, and that essentially is giving you that distance away. So I hope that wasn't too confusing, but in a quick description as well, what does 2400 mean? At 20 feet, the normal person can read that letter at 400 feet, okay? So hopefully that helped clarify things, because I realize as a physician, we kind of go through and we say all these things, and the data, to us, it's data collection. We're trying to understand and track your data, but to the patient, they don't understand what that means. And does this relate to real life, real world? No, it's us understanding how well you see, but in real world setting, there's sun, there's glare, there's noise, there's other factors. So is this a real world setting? No. Okay, so I do have patients that go, in my own house and in this lighting, I can't see very well. But you say that I can see 20/40 or 20/20 and I see good in the exam room. That does not interpret to how real world is, and I understand that. But this is the data that we collect because, one, it shows us our monitoring of effectiveness and of clinical treatment, as well as the disease progression. So it's our way to track you, okay? Sorry, long description there, but I just wanted everybody to understand that can be a little bit of a confusing topic. So again, we're continuing with the low vision exam. Again, you might think this is a really long exam, but yes, actually our low vision exams are quite long. They're usually over an hour, and sometimes my patients even get tired. So I'm getting tired doing this lecture, you know? I mean, we're just gonna keep on discussing the exam because it is a long exam. You know, I always say, drink your coffee because we're gonna need you to stick along with this exam. So we're almost done here with describing the low vision evaluation. So please hang in there with me. We want to, during this exam, not just acquire a lot of data and check vision, but we also want to have you better understand or educate you about the disease process that you're suffering from and why the vision is impaired. We do find that patients have a better understanding and acceptance of their vision once they understand the disease process, and sometimes this does take time to sink in. We are human. We understand that everyone reacts a little bit differently, and this may be a good reaction or a bad reaction, which I'll talk a little bit more about depression later. We do ask the patient as well as the family member or caregiver in the room how the patient is doing with mobility. Sometimes we do find that patients will say not much, or they just don't complain. And then the family member says, oh no, they fall and I'm concerned for this and that. And that's very important to know because some patients are a little shy. We do ask about driving. It's probably the most common question I ask. And if the patient is not legal to drive in the state of Florida, you know, we have to have that difficult conversation. If there's been concerns for close calls or even motor vehicle accidents, usually we do. I personally don't report patients, but I do kind of discuss that and even relay this information to the primary care. Does the patient appear depressed? You know, that's a whole, you know, another spectrum. Usually we do suggest counseling and support groups for someone that we feel like is depressed. Really quick side note, in the state of Florida, these are the requirements. I have them committed to memory because I talk to so many patients about driving. So just so you know, if both eyes open, you do achieve 20/70, which I do feel like this state is very lenient. 20/70 in both eyes, you are legal to drive. But if you have one eye that is worse than 2200, the other eye, the fellow eye, has to achieve 20/40 vision to visual acuity wise be able to continue to drive. Now there's two requirements for the state of Florida. It's not just vision, it's also uninterrupted peripheral vision, okay? So hey, you have to have 130 degrees of uninterrupted horizontal visual field as well, okay? So there's two requirements in the state. And also, in case there might be individuals in the audience that might ask about telescope devices, the state of Florida does not authorize telescope devices. Now, Georgia, that's a different story. So again, I did say I was going to discuss a little bit about depression. I have seen many reactions in my exam room. The most common, I would say, you know, is going to be sadness. I have plenty of tears shed in my room, and it definitely can make my job a little bit difficult because I'm an emotional person as well. But just a really quick kind of rundown of the process that we need to be aware of, that there are stages. The first stage may be denial, numbness, shock, followed by maybe bargaining, and anger, depression or loneliness. Reflection is part of that too. I know I have them numbered 1 through 4, but that does not mean that someone can go through those in any order. In particular, it can be completely out of order. I've had patients start off angry, you know, and those are very exciting exams because you never know what's going to happen. But you have to, we know we have to step back and let the patient process things on their own time. And then when they return, hopefully we can get more done with the discussion and with seeking whether it's services or visual aids. But there is an upturn, you know, there is an acceptance, there is a hope. I do have plenty of patients that are just wonderful to work with, and nothing stops them. They're just great. They inspire a lot in me as well as my staff. Just a really quick bit of statistics. This is a study by Brody and Associates about depression, visual acuity, comorbidity, and disability associated with age-related macular degeneration. This was a study of 151 subjects, roughly about 80 years old. The average vision, though, was quite poor, 2200 in the better eye, and this is categorized as legally blind. So about 78%, sorry, talking too fast today. 78% of them also had a comorbidity, such as high blood pressure, heart disease, or thyroid condition. And what this study found is that 1 out of 3 of the elderly participants met the depression criteria. So these results are twice as high than the general elderly population. And so this is a direct correlation that vision or profound vision loss can have a terrible impact on depression in this group of individuals. So if you haven't quite noticed, we're kind of running to the end of what kind of the purpose of the low vision evaluation is. This is what we hope to achieve. We hope to achieve just simply better vision with just trying a trial frame refraction. That is this device. You see these little red lenses going in. It is a more friendly, more natural kind of device we use to check vision. We use loose lenses. The patient's usually more comfortable, not looking through a big machine. And sometimes we're lucky, I would say 50-50 chance that patients sometimes improve vision just by glasses. If no one has ever tried, I can at least tell you we try, okay? But that does not mean that we're always successful, but we do try. Sometimes I do have patients that I give take-home tasks and helpful suggestions for at home. Successful, hopefully, patient education. The patient will walk away as well as a family member walks away with an understanding of their disease process, availability of programs for them as well. I am also a bridge. I would say that is kind of my main role for patients as well, is that I'm a bridge to other supportive services, whether that's occupational therapy. I mean, I'm really listening to the patient, and if I'm hearing anything concerning, I can even do a referral to a specialist, whether it's neurology, internal medicine, dental, if I'm listening to all the problems. If I feel like something's not being managed or cared for, I've even been known to write an email to the primary care if there's a concern. So I do a lot of writing. I'm a big patient advocate, but sometimes there's patients that come in that that live alone, have no family members, have no one caring for them, and I do have to kind of get skilled nurses into their home or care just to make sure they're taking their medications correctly and things are safe at home. I work with psychiatric individuals as well for counseling, and of course the Division of Blind Services, and in our own community, elder care. But we do want to help the patient as well with visual aids. If I have a visual aid, I think that they would do well with, but I do not have it available in my office. I usually do seek a representative to go to the patient's home at no cost to show them that device. And that's why I talked about referrals for a home evaluation. Now, these are quite numerous, but these are a lot of visual aids that we have actually in the office, and some of them have become a little bit obsolete. As you can see, a lot of them look like they're handheld or wearable devices, high-powered lenses. We've got some mountable telescopes there. There's lots of options for wearables and handhelds, but a lot of people now want to be hands-free. So this is why I put this slide on here, because I feel like there's definitely a past and then there's a present. We are moving towards a more digital, liked and digitally accepted devices to help with magnification. Routinely, they're usually small cameras that have the ability to project onto a screen, or they're portable, looks like a little cell phone, a digital magnifier, quite useful and very handy and discreet in some ways. Some other visual aids that are very, very simple is kind of a gooseneck light that has a magnification lens right in the middle. That is something you can purchase over the counter, as well as an OT light. Yes, some of my patients that are very visually impaired on an extreme level or have very limited peripheral vision do use a guide dog, and they have to undergo training for those services. But simply a large dial phone, large print playing cards, a talking watch, all these things are over the counter and can really change someone's life. And it sounds simple, but sometimes patients don't know to seek those devices out or that they're available. Now I put this really large remote control, but nowadays I am actually hearing a lot about the smart TVs and the smart remotes. So many of my patients now just talk to their remote and they don't even mess with the buttons. So I definitely would say that the smart TV, smart remote is the way to go. Keep it simple. So how does someone purchase these devices? Now, if you're looking for a specific company, yes, you can purchase them through me. Most low vision specialists have accounts through any or all companies to purchase these devices. If you're independent, and you want to try to seek online, you certainly can. Used devices are quite commonly found on eBay. I do write a list usually to the patient of devices they liked during the exam. So you do get that information. It's part of your record to take away, and you can do with it what you would like. I also work with quite a few companies that have representatives, like I said, that no charge, they can come to your home, show you the device, you have no obligation to purchase it. Again, I have no disclosures, so because there's quite a few names here, and I am not biased. I try to show if something's good, I show every company's brand in it. So everything's a little bit different. The prices do vary. So some patients do say, and I do have some patients, I don't have any devices to show them. If the vision is very profound, and they've had significant vision loss, if there's no light perception, worse than 2400 or hand motion, there is very few devices I could use to improve vision. So at that point, we usually talk about text-to-speech devices, okay? And this can happen from a severe age-related macular degeneration. So it does limit us to what we can use, okay? And just so you know, I know I'm throwing out a lot of definitions. We've learned, the legal, what's legal in the state of Florida to drive, what visual acuity is, and what that fraction means. And now I'm throwing another definition at you, the definition of legal blindness. Why is this important? Because individuals usually want to have a means to work with Social Security to supplement their income. So this is why this is very important. This is defined as the better eye reaching an acuity of 2200 or less, or what I would say is worse. So meaning their better eye does not see better than 2200, or they have a visual field in their better eye that is limited to less than 20 degrees of useful vision, okay? No, an individual does not qualify as being legally blind if they read a few letters off or better than 2200. So they're definitely, this is a very, very strict definition. A few more visual aids that I sometimes suggest for severe visual impairment, like I said, are going to be a lot of your digital devices that are text to speech. These can be, as simply put, they are like little hovering cameras, okay? They're a camera that can essentially take a picture, screenshot, and read you back what the page in front of it is saying. So it reads it to you, you can scan it. VR devices are becoming very popular. VR means virtual reality devices, but I'll be honest, not everyone can wear them that long. Sometimes you might feel uncomfortable, but I do believe one day that virtual reality devices will probably be the way of the future. They're pretty amazing. I have one in the office. It does not work for everyone. I have learned this sometimes the hard way. So I do try to not get people too excited about it, because sometimes you never know how someone will do with something when you give it to them. It is all based on each person's reaction, the disease process, the severity of vision. And so I usually just leave it in the patient's hand and I let them give me the reaction. And sometimes we're lucky and sometimes we're not, it just depends. The one device here on the bottom right is called the OR cam. That has gotten a lot of, I would say, attention lately because they just recently made it into a pen as well. It looks the same size as that device that's connected to glasses, except it's held. And it literally, if you position it correctly, takes a picture of the page, reads the whole page back to you. It can identify colors. It can identify, as long as there's a record, identify a person's face. And it's only this big. It's very, very small and very portable. So they're just becoming quite popular. Now, as far as cost goes, this is probably the most depressing part of my job, is knowing that there's a device that works for someone that they can't afford. Because none of these devices are covered by insurance. They are not medically necessary, even though it makes sense to say it's medically necessary, but they are not covered. They're all out-of-pocket expenses. So, you can determine whether this is reasonable or not for you. But it's something as simple as a clip-on might cost, $13 to $20, whereas a cover over or a secondary sunglasses, I call them solar shields. It's the most popular brand. That can range from like $15 to $30. But if you get specific brands like Havens or Cocoons, they can be upward to $60. They work very, very well and they have good optics. Handheld magnifiers are the largest range, I would say, because you could get companies out of Germany that can charge, upwards of $200 for a handheld magnifier. And you might find something at Walmart or off Amazon that's $20, maybe $30 that works just as well. Same size, same power. And of course, you do need an LED light in the handheld magnifier for it to be worth any money, okay? But there is limitations to what you can purchase on your own. So be aware of that certain strengths might only be achievable through a company. Now, the digital devices that are tabletops, something that's not portable, that would stay at home, that's quite large, would be around $3 grand. You can find them used, but usually if you're paying $3 grand for this device, it has all the bells and whistles, text to speech, contrast changes, meaning you can change to inverse. You can make a white background, a black background, okay? Lots of options and almost unlimited magnification depending on the screen size. I personally like handhelds that are more portable. And one of my favorite is the SmartLux Digital, which is down here on the right corner, but there's many companies with the same size device and multiple ranges of cost. So they can cost from $250 to roughly $600. But I just find that patients like more portable devices, something smaller. They can even lay back in their chair and read with it, and their arm doesn't become too tired. Number one helpful tool, though, that I see more and more. I used to only see it with my younger patients that are visually impaired, children, teenagers, maybe middle-aged, but now digital devices all the way, number one. If you know how to work that smartphone, it has every means to keep you plugged into the world. You can shop on there. You can have transportation there. You can get groceries delivered. You can have your recipe for cooking read to you off your phone, whether it's through a low vision app or a service just through the settings in the phone. It's quite impressive, and it keeps people very happy because then they still have their independence. That's the whole point. They still interact with individuals. I find that even the Kindle, you can control your font size, your background color, the inverse settings. So you just have a lot more control of your settings versus just a book, right? Now I own both books and a Kindle. I love both, but when it comes to vision and expectations, you want some form of control. I also added in, this is a wonderful, and I wish I could just dedicate 5 slides to this journal article, but I found this a little bit late. but it's called the then and now top assistive technology for the vision loss community. I have read this, and it is an article that in just simple words almost takes my whole PowerPoint and puts it into usable information. It also goes into information about multiple apps, about 6 or 7 apps. Some are at no cost to the individual, and others do have a little bit of a price tag, but they all work very well and they have great reviews. I've had patients that use those apps. So if you want a little bit more information, this journal article just came out in December 2020. It is so helpful. I have the link here as well, but if you just want to look up really quick, you know, in Google search, then and now, top assistive technology for vision loss community, that article is wonderful. So it goes over a lot of digital devices, things I can't quite cover fully in this lecture. So please give it a second look. Now, I can't give a low vision lecture about my low vision exam without kind of mentioning some very unique, specific things that University of Florida participates in. So I call this the team approach because it is very much a team approach. We provide Argus 2 as well as implantable telescopes for patients that meet those requirements. So I'm going to talk a little bit about this because it does get out into the media, and it's aware, the community is aware of these devices. So I didn't want to not touch on them, considering that there's definitely a lot more awareness now. So this is specifically the implantable telescope. I am part of this team. The team is a retina specialist, a low vision specialist, a cornea specialist, and an occupational vision specialist. Okay, so quite a few people are in the kitchen cooking up this. So a little bit about the implantable telescope, specifically the criteria. So this is not a common surgery done because the applicant has to meet certain criteria that's very strict. Okay. It is covered by insurance if this person does meet the requirements, but this is only for age-related macular degeneration patients only, as well as they need to meet to certain criteria here I've listed. They have to be 65 years or older. They cannot have had cataract surgery already. The vision has to be, you know, pretty poor. They have to have central vision loss between 2160 to 2800. Again, this kind of sounds like the definition of legal blindness. So yes, the individual has to be almost legally blind, which is very, very poor vision. We don't wish that on anyone. But they also have to have no concurrent retinal disease, and they have to be willing to participate in a lot of therapy following this type of surgery. The mechanism of action is quite fascinating because we use handheld telescopes all the time for patients in the office to look through. We can also mount them on glasses or clip them on, but in this case, the telescope is actually put into the eye. So the idea is you have this central scar tissue from age-related macular degeneration. The telescope magnifies larger than the scar tissue, allowing the individual to see small letters and things like that. So it's getting around that scar tissue development. It essentially provides magnification, the ability to see small details. You don't have to wear something, so it's, you know, it reduces it makes you hands-free essentially, and improves vision. I usually find about 4 to 5 lines in the office, but if you want to think of it as, if it's magnifying the image, it's minifying the scar tissue. So there's kind of 2 different ways to think of it. But it does permit natural eye scanning because it's in the eye, so you can move the eye more freely instead of having the cumbersome device outside. Improves recognition of, again, reading, TV, identifying people at distance and near. Does not mean you'll be glasses free. I do fit these individuals with glasses both for distance and near after the surgery. So the one trade-off is that the eye that has the implantable telescope, because it's just one eye that we do that surgery for, it loses its peripheral vision. So as you can imagine, this is why there's so much training involved with this device, because the telescopic eye gains central vision, but loses peripheral vision. And so it gains distance and near. but the fellow eye is left alone, and that is the peripheral vision eye. So these individuals learn to have kind of a monovision approach. For those individuals that are listening that have worn contact lenses that do monovision, one eye does distance, one eye does near. In this case, this type of monovision is one eye does central vision, no peripheral vision. The other eye does mobility and peripheral vision. So this takes a lot of training. I like to say it's like a new visual workout routine. So we definitely have to have a patient that does not have dementia, is very cognitive, energetic, and there's of course lots of follow-ups. You know, you get clearance from me visually, you get clearance from the retina specialist, and then the cornea specialist is actually the one that does the surgery. And then afterwards, you meet with occupational therapy, and you work with occupational therapy as well as myself. Eventually you get fit with glasses, and we work with you. And then once after the kind of the post-op period, vision just settles in and patients are very happy. But there is a lot of follow-ups involved and a lot of time and work. So just a little bit of research. The best corrected vision does quite improve. In this case, in the study, we have some odd numbers here from 312 at baseline to 2141. So that's a good 3 or 4 lines, even 5 lines improvement. Statistics do show an improvement in the quality of life. What I always like to know from studies is how many patients weren't happy, right? So there is 5 out of 200, so 2.5% that during the phase 3 trials felt that their vision was not improved, but this is a very small amount. A lot of patients were very happy. There's also, of course, risk with this type of surgery, with any surgery, but there was no retinal detachments found after 5 years of follow-up. If you do want more information, there's quite a few video clips as well on their actual website. The company's name is Centrosight, and you can feel free to educate yourself. This is a study that is concluded, but I do feel that there is always advancements in this. So I would keep your eyes out, right? We're looking out for any new advancements in this. Centrosight might come out with a few more things. The last device I'm going to talk about can be the most confusing. So this diagram, I'm going to try to sum it up quite simply, but this is Argus 2. It is a study that is still ongoing, so you won't see me kind of quote a lot of research on it because we're still waiting on that research data. We did participate in this study. I personally trained these individuals after they had their device implanted, and I worked with them with interpreting vision and therapy. We have since had an occupational vision therapist step in and kind of fill my role, which has been very helpful because she can spend a lot more time with them. I'm a little bit constrained by my work schedule. So this is FDA approved in the United States, and you mainly are managed by a retina specialist and now a vision occupational therapist. So you don't have as many chefs in the kitchen, right, as you did with Implantable Telescope. Specifically, this device is only for individuals that have a disease called retinitis pigmentosa, which slowly does take away peripheral vision. And usually patients that have this device or qualify for it have severe visual impairment, even so much so that they're barely light perception. So this is very poor vision, okay? The best description is that there is a implanted device in the retina that a retina specialist does a surgery for. That implanted device can have transmitted frequencies sent to it from, you see this wearable device this gentleman's wearing, has a camera in the middle. The camera is essentially your view to the outside world. Where your face is pointed is what it will see, right, and what it will scan. That takes visual information and inputs it into kind of pulses and transmitted pulses to this little microchip that's in the eye. And those pulses are supposed to mimic kind of the excitability of the cells of the retina into sensing light versus no light. So on and off is my best description. Now remember, this is not the kind of vision that you and I would understand or are aware of or have ever sensed in our life. This is man-made vision. So it's very pixelated, very on and off. So it's not really colors, it's black and white. Very unique. In training these individuals, there is a huge learning curve of training, but they get to where they identify edges, corners, as long as there's good contrast, plates on tables. I mean, it gets to where in the beginning, they don't understand or see anything. They see light, no light, and then they get to where they can understand what that light, no light, or on and off means. It is quite fascinating, and the individuals that get this implanted are very happy. But to tell you that it was a simple fix it's not true. It takes a lot of training. Just, I guess, like a lot of things in life, right? Wish it was more simple, but maybe one day they'll work on the next advancement in Argus, and things will be simpler. So, but these are the two main kind of team approaches that we're currently working on at the University of Florida, and I thought you would like to know. This is kind of one of my conclusion slides. You know, in general, how can you help? If you are a patient, please continue your therapy that's ongoing by your specialist. If this is allowing you to hold your vision or achieve vision that's stable, please continue it. If you're a family member or caregiver, we want you to continue giving that care and empathy to that individual that is your friend, loved one, or family member. We hope that, you know, today you walked away with learning a little bit about the disease process and how it can affect vision, and how individuals with vision impairment can approach the world, and maybe a little bit of empathy of understanding how things might be a little bit difficult for them and things they have to overcome. We do want you to inquire about the mental state. I think with COVID and everything that's been going on, there's been a lot more awareness about everyone's mental status and awareness of emotions. And so I think that when someone doesn't talk about certain things, we can still find ways to bring it up, that to kind of say, you know, hey, how are you doing? How do you feel about this? You know, instead of just kind of ignoring them and just kind of tippy-toeing around the problem, that this needs to come up and we need to talk about mental awareness. Of course, simple things you can do. Sure, you can buy a lot of these devices just yourself over the counter. But one of the simple things you can do is change the lighting in your home. That is just something that you can do on your own, improving the lamp that maybe you read with, lighting in the home to where you don't trip or fall, exchanging those old light bulbs for LEDs a little bit brighter. And that can really just make a world of a difference. Staying active in the community, you know, it is difficult with COVID. Things have changed tremendously. That doesn't mean we should just sit at home and not do anything. You know, we need to make sure that we're active in the community as much as possible. Whether, you know, you're participating in a lecture like this and educating yourselves, or maybe just doing social distancing and getting outdoors and leading a healthy lifestyle. Of course, I'd love to see any of you if you feel like that you need a low vision assessment. I'd be happy to help. So concluding remarks, hopefully no one's fallen asleep. This is the end, so hang in there. We don't want you to wait until you feel like you have significant vision loss. I see patients that have vision changes and come in at 20, 30, 20, 40. If you feel like your activities of daily living, there's something you can no longer perform and you want to see if you can do that again, don't wait till you have all this vision loss. Just come in and see me. We can do a refraction and check things over. We want you to walk away with an understanding again of what the condition is that's affecting your sight. I probably said this 5 or 6 times, but that definitely helps with awareness and understanding of expectations. Having empathy for these individuals. We certainly have a lot of empathy. I've seen all the stages of depression, but as I like to say, you need to be a little bit stern as well. You know, I always say my family's taught me tough love. You can only whine for so long and cry for so long. You've got to get out there and be proactive and help yourself. And hopefully, maybe if you are struggling a little bit, you have someone around you that is strong enough to help you too. So we're there to give you a shoulder to cry on, but we want to be positively moving you forward, okay? My best patients, I call them my all-stars. are the ones that have, thankfully, very good family support. But it's also their personality, their mental drive. They stay positive through so many things, and they can be hit with so many difficult tasks to try to achieve or try to move through, and they still come out on top. They still stay positive. They're hopeful. That positive energy definitely helps, I feel like, more patients to learn new things. They're open to any discussion, and they really just, like I said, they're my all-stars. Nothing ever stops them. But having a good outlook on life and good family support is also very, very important. I really do truly enjoy my job, if you haven't noticed. So if you have any questions, you can feel free to email me. I have realized that I know I'm sitting here, and you can't see anything lower than this screen, but I'm actually currently expecting, and I will be out on maternity leave here coming up very, very soon. So if you do email me and I don't get back to you quickly, I do apologize, because I will be out of the office here quite soon. I'm sure Marcia would say something here in a little bit. But please don't get off the line here. We are going to ask you for questions, but there's also another guest speaker. Casey Ely is going to talk to you about a program that's very near and dear to my heart that I use quite frequently with my low vision patients and for really our community members. So please give a warm welcome to Casey.
Thank you, Dr. Cameron. Good afternoon, everybody. That was a wonderful talk and such great information and great resources. One additional resource we wanted to share with you today. I am Interim Director of Elder Care of Alachua County, and one of our programs that we have that serves our community is the Independence with Low Vision program. That's a partnership with the Florida Division of Blind Services and Elder Care, and it's really for those who are suffering from severe vision or blindness. The goal of our program is to provide training to adults and seniors who've experienced this situation, and really to work with them to enable them to live safely, independently in their homes, travel safely in the community, and provide solutions to improve quality of life. We do that through several different scenarios. We do home-based training, we do individual training sessions, we do group classes. COVID has made that kind of challenging for us in some situations, but we've been creative in solutions and still able to work with our clients. We also have some series of classes as additional resources. Right now we have a 10-session independent living skills class. We have an 8-session adjustment to vision loss class. And then we also offer a low vision support group. Some of the ways that the programs help through these different opportunities for classes and training are working with some of the devices that Dr. Cameron showed in the presentation, helping someone adapt in their current living space and environment to using things like those devices, how to implement them safely, how to understand. There's so many great features with our smartphones and devices that you may not even know exist, but that's where our expert team comes in to kind of help walk the individual through that, let them know what's available to them, and then really learn what their needs are in their individual situations, so we can help with different trainings, such as how to use a long cane to detect drop-offs, to ambulate safely, how to use the magnifiers, teaching different labeling and organization techniques to assist with things such as medications. Dr. Cameron mentioned that a lot of people suffering vision loss or blindness have a lot of other comorbidities, and those medications are important, but learning how to administer them safely is another way that we try to help. So I wanted to throw that out there. If you or a loved one or a caregiver or someone that you know that you think might benefit from these programs, you can give our team a call at the Elder Care phone. It's 352-265-9040. And Marcia is going to send out an email to everybody after the conclusion of the program that'll have that information, also a link to the website. But please, if you have any questions or feel that there are resources we have available that maybe could be helpful to you or someone else you know in the community, we just wanted to let you know that was there and extend that offer to you. So thank you all so much for listening today. And Marcia, I'll pass it over to you.
Okay, so we've had a lot of great questions come up. I'm just going to get right to them because I know that people are pressed for time. So my mother had macular degeneration. How much does that increase my risk? And I think Dr. Cameron, that would be a great question for you.
So we know this condition is genetic, but it's specifically, I actually don't know it depends. So there's a lot of genes that are involved with age-related macular degeneration. So the penetrance of that genes, I mean, if you had genetic testing, you might be able to know genetically between you versus your siblings, what percentage. But normally what I tell patients is that you need to start having kind of regular eye exams starting at age 50, and then from kind of then on until, you know, something's identified or not. But it's, sorry, that question is very good question, very specific, but as far as a percentage, no, because it can skip siblings.
Okay. And so related to that, are there supplements that are good for macular degeneration?
Yes, so there's actually quite a few because the market has become very just aware of age-related macular degeneration. So there's quite a few like Preservision, Ocuvite, MacuHealth. Some of them you can only purchase through a physician's office. Like I said, these are delivering specifically lutein, zeaxanthin, very orange pigments that the retina needs, as well as sometimes these formulas incorporate omega. So you can kind of individually supplement those or eat a healthy diet. It's not just carrots, rich in leafy greens like spinach and kale are your highest nutritious food groups that you can have, and also supplement that lutein and zeaxanthin if you're against pills. So.
Okay. We also had a really great question. Is a low vision exam covered by Medicare?
Yes, actually, I bill medically. Specifically, I'm one of the few providers that bills time as well. It is covered by insurance. Yeah, I use medical diagnosis during the exam, and I actually, it's one of the few clinics patients never complain about any concerns for copay. So yes.
Right. Someone asked, I have severe astigmatism. I'm 66 and I would like to know if this is progressive and can eventually lead to low vision impairment.
So astigmatism is unique in that it actually is completely correctable with glasses, but if it's extreme, it might actually be only correctable with, or fully correctable with rigid gas permeable lenses, contact lenses, or contact lenses just in general. We have a specialist here that fits extreme powers of astigmatism as well as spherical powers. That's my colleague, Dr. Penny Strawn. And there's lots of modalities now in the contact lens, rigid contact lens industry that have changed over time. They've become a lot more comfortable and easy to use. So that would be, besides cataract surgery, that would be my suggestion for correcting just astigmatism.
Okay. Here's a great question for Casey. How can someone with low vision who cannot drive get to some of the classes that you mentioned at Elder Care? Or how are these classes presented?
Well, a couple different scenarios. And at the point that you speak to one of our specialists, they'll kind of walk through your individual needs, do an assessment, and really see the best way we can help. We do home-based visits and training. It's really important to make sure that we help someone adapt to their individual living space. We've gotten really creative with COVID. Some of the classes that we would do in person, we're using a program called Uber Conference right now, where we can actually dial in the participants so they don't have to put all of the numbers that Zoom requires, since that's hard to see on a screen. But we can actually get people into a group setting for discussion and dialogue still. So we're getting really creative with that and how we can adapt to those that can't drive and the limitations that COVID has put on us right now.
Okay. Let's see. Someone, here's a good question for Dr. Cameron. Someone says, LED lights are very painful for me. Any suggestions or other suggestions for just home or office lighting?
So I did mention in my lecture switching out lighting, but some individuals are very sensitive to the glare with LEDs. I hear that complaint quite a lot. That's when I would suggest wearing some people do not like wearing fit over lenses or sunglasses over their current glasses. I personally, I like it because I feel like it's another form of protection, especially when I'm outdoors. So I'm definitely biased that I like fit over sunglasses or tints. I don't personally like to permanently tint my lenses. But if you end up liking a tint, it's a tint that I would suggest, either yellow for indoors, like standard yellow. I call them shooter glasses because a lot of times, this was coined from the military on the shooting range. You'll see individuals wearing yellow tinted glasses. It helps with contrast. So with those LEDs and glare, I like yellow tint and I like rose tint. Sometimes a very faint gray can help with that sensitivity. If you have headaches, a very fancy tint that is very similar to rose tint is called FL41. This can actually be purchased online as well to have in the sunglasses that fit over your glasses. But I just use tints.
Okay.
Really, LEDs, yes, they are bright. You can find the spectrum, like a warmer spectrum that could help, but it is difficult. It's difficult to find a happy medium.
Okay. So someone says 20 years ago, I was successfully treated for pseudotumor cerebri. I'm hoping I'm saying that right. And does having this put me at greater risk for low vision?
So that's a very, very good question. I see plenty of pseudotumor related diseases in my clinic. So that's a tough question because it depends on how affected the optic nerve is during that event. If it was an isolated event, meaning happening one time, I would say that your risk is very low. But some of my patients have recurrence of the intracranial pressure, and then they have bouts of swollen optic nerves, healing process, swollen optic nerves, so active and inactive stages. And then it's that inactive stage or the severity of how swollen or bad the active stage was that can lead to a progressive loss of optic nerve cells over time. There's no way to know, there's no way to know if you're going to have that something called optic nerve atrophy over time. But if it's been many years and it was an isolated pseudotumor event, I would say your risk is very low. We see it all here. So I've seen everything where patients are normal years later, and then some patients are slowly losing vision. Usually that does plateau though. You do not go completely blind.
Okay. Someone asked about tinted glasses. Should they be worn at night to decrease headlight glare?
So you have to be careful. In the state of Florida, you cannot wear certain sunglass tints. I would say you're safer with yellow or a faint rose tint or a faint gradient of gray. But if you get stopped by law enforcement and you're wearing a dark tinted lens, I think you get a ticket for that. So you have to be very careful. There's lots of pedestrians in Gainesville and they don't always wear very reflective clothing. And so if an individual's wearing dark clothing and walking along the road, if you are wearing a tint, that might just be enough light that you're not seeing and you don't see them. So I don't suggest tints for driving unless they're yellow, which is a very faint, very clear kind of color, or rose, and that's it. Yeah, no dark sunglasses at night.
Are there any particular type of characteristics to regular glasses that would help? Things that, like someone else had a follow-up question about that night vision issue after a cataract surgery. And they want to know what kind of glasses would help at night.
So everyone after cataract surgery is a little bit glare sensitive. And I will say that sensitivity slowly goes away. I can only say that because I've experienced it with quite a few of my family members, as well as I hear this from patients. you can use a light tinted lens, but really making sure your glasses have anti-reflective coating. I know some people like to poo-poo the anti-reflective coating, but that anti-reflective coating allows more light to get to your eyes, and it doesn't allow glare. So
Yeah.
it doesn't allow light to bounce off the glasses, and then you don't see as well. So I would say the first thing is anti-reflective coating on your new glasses following cataract surgery.
Yeah, I remember the first time I said, okay, I'll try that one time. And I was like, worth every penny. So kind of along the question about glasses, someone says, I struggle to get a proper glasses prescription. I feel like I'm always told to guess at the chart, and then I get an inadequate prescription. What could I do to improve the outcome?
So this is a loaded question, because I completely understand, because I wear glasses myself and I even refract myself, and it can be difficult because you think some days you're going to see well and some days you don't. And that is true for refracting. There are some days that we will have a good refraction for you, and your power will change daily. One click here, one click there, not considered, within a range that would be significant. Small changes like that do not even reach what we'd call a standard called just noticeable difference. But people are concerned because the vision exam is kind of like a test. And so people do get nervous. They feel like they can make a wrong decision. Physicians and staff, we move kind of fast. I usually my staff is very good, and we tend to listen. If the patient feels like they're being rushed or we need to slow down, we do slow down. But a lot of times the individuals are dry. So we do use lubrication drops to help with clarity of their vision. But sometimes if you're feeling like you're not getting that exact power, there's lots of factors involved. Is there a cataract? Why are we achieving 20/20 anymore? Is there dryness? Is the pupillary distance off? Is the material something you like? Is the lens too small, too curved? There's so many factors that can influence how you feel when you have new glasses. It's not just the refraction.
Okay.
Loaded question, sorry.
Okay, we got a question about double vision, or they called it astopia. They thought that having cataract surgery would help, but they still have problems with it. Their optometrist said there might be some exercises. So are there exercises that can help? And do you have anybody who's a specialist at UF Health that treats that?
Yes, we do. Usually we only suggest exercises when you're younger. If you have a weaker eye that likes to turn in or out, when you're younger, we do suggest vision therapy techniques. It's never wrong to continue those skills, once you're older, and if you understand what the practices are, because the eye muscles are a muscle. In extreme circumstances, if the eye is very turned, we have wonderful specialists here, specifically Dr. Casey Beal, who is a surgeon that he fixes large strabismus or large exotropias, esotropias with surgery. If they're small, we tend to use Prism. I, again, would suggest Dr. Casey Beal. He's wonderful. He can use both, and he can determine if whether Prism will help. Prisms are essentially glasses. They'll look just like normal lenses in glasses. They just might be a little thicker on the top, side, or bottom. And that shifts the image to where the eye likes to rest. Whether it's the eye is in, the image will be shifted in. If the eye is out, the image will be shifted out. And so that is correctable usually. Your history of having cataract surgery to help improve this, if it was always an eye muscle, cataract surgery does not help that. Cataract surgery or cataract removal only helps clarity or to clear up the image. And if you have double vision, in that case, maybe definitely cleared up a second image, right? And so you definitely want to seek someone who fits or performs that surgery to straighten the eye muscle so you can see single. And like I said, Dr. Casey Beal is wonderful. He treats our pediatric as well as my adult patients that suffer from eye turns or strabismus.
Okay. Is acute angle glaucoma a type of glaucoma? Like, is it an early warning sign or just another name for glaucoma?
So acute angle glaucoma is a form of glaucoma. Usually it's treated with a laser that equalizes the pressure between the anterior chamber and the posterior chamber. So I would say it is correctable or treatable if caught early and the pressures are not high for prolonged periods of time. I have an aunt that had or underwent that laser at a very young age. And usually after the laser therapy, as long as the pressures stay normal, that's the treatment process. Although you would want regular eye exams just to make sure that glaucoma or optic nerve changes aren't occurring. Because remember, glaucoma is painless vision loss and it's a long duration, meaning that for 20 years you could be normal. And then after 20 years, something in the nerve could change. So it's something where I say suggested, not yearly exams, but at least monitoring over time.
Okay.
Sure, there's no changes, but it's usually kind of a therapy, the therapy's done, and then your risk is a lot lower.
All right. Are there new procedures offered for macular hole besides draining the eye? And do you do any of these new practices?
So that is a good question for one of our retina specialists. We have 4 retina specialists now. And I am not a retina specialist. Like I said, I'm like that bridge. I get you to where you need to go. I can do your eye exam, check everything over. And then if I find that you need a specialist care, I get you to that specialist. But as far as what I know that the main surgery is a pretty invasive retina surgery to try to get rid of any traction, flatten out that hole. But as of right now, I am not the right specialist to ask that question to. So good question though.
Yeah. Can you talk about someone's been diagnosed with basement membrane dystrophy, and will that eventually affect their vision?
So anterior basement membrane dystrophy is very, very common. At least I see it all the time in my practice. Some patients are completely asymptomatic, which means they have no visual symptoms, no symptoms of eye pain. And then the other side of the spectrum is they have all these visual disturbances, inconsistent vision, eye pain. You know, the main treatment is lubricants. So you need to keep the surface smooth, lubricated, healed, even using eye ointment at night to prevent those scars from occurring. But if the scars go to the center of the vision, your vision will be impaired or changed. But those scars tend to move. They kind of move around. And if the more lubrication you use and the more moist your eye is, the less chance those scars are very dense and they don't affect vision. There is many stages to age-related macular degeneration. I'm stuck on that today. To anterior basement membrane dystrophy. If it becomes significant enough to impair vision, usually we suggest a cornea, a ophthalmology evaluation with one of our specialists here. We have 3 cornea specialists, and they can do a procedure to resurface the eye, and that clears all that scar tissue up. So I have had vision compromised to about 20/30, 20/40 at the most. But then I refer to the patients for that type of procedure and it clears everything back up. But it's the mechanism of the disease. You know, it'll come back. You just have to know how to manage it. So it's a lot of work using eye drops. I use eye drops too, because with the digital screens and everything, everyone's a little bit dry. So it is a lot of work, but usually no vision loss from that, not significant vision loss.
All right. Well, that's about all we have time for today. I appreciate your time and I appreciate the time of everybody who watched and submitted questions. There's a few that I'll try to follow up with those people about those questions later, but I'd like to thank you again for your time and enjoyed your talk today. Thank you so much.
Thank you so much, Marcia.